early on at school for both genders, where you respect your body, you clearly know that your body can serve you well, but each part of the body can also undergo certain changes that are critical to be aware of. I think we've spent quite some time about talking about early detection mammography. The one thing I hear often is people are afraid of identifying a tumor, even though they may be aware of it, because the treatment, they say, is worse than the disease itself.
Yeah.
Oh, you will cut me, you'll give me chemotherapy, radiation. When I came to Kenya, there are two words I heard in Kenya. Well, I knew them before. Nyama choma, which is good, or choma. The choma is to say, if you give me radiation, you'll choma me.
Yeah.
Doesn't exist anymore. We don't choma anybody. In fact, we choma the tumor, but not the patient. So I think we should also bring about awareness of the types of treatment we use for curative intent for breast cancer. Yes, they could be painful, but a short amount of time, but they allow us to really provide cure. And I think we talked about this when I came last time. Just like the breast cancer is fertilized by estrogen, if you have a receptor, which is a macroscopic mouth, that is the HER2 receptor, we can block that receptor because that's also a fertilizer for the tumor. We can cure women today. Recently, we did a study in women with breast cancer who are HER2 positive. We gave them chemotherapy plus anti-HER2 to block that HER2 mouth. We cured all 8 women who came on the study.
What?
Nearly unheard of. But you need to have the right testing. Is your tumor ER positive, PR positive, HER2 positive? Not enough to say, I've got breast cancer. Identify the pathology of the breast cancer so that we can then treat you in a targeted fashion. So I think treatment is improved significantly and life can go on. So it is not fair to say the treatment is worse than the diagnosis of the disease today.
You see, right there is where the disconnect is. Because when you speak positively, you speak hope, you speak life. But when we don't have that knowledge, then all our fears and superstitions around cancer is our lived reality. We ask this question over and over, and we're going to ask it again. The Aga Khan University Hospital is a teaching hospital. Do we have outreaches or do we have plans to ensure that our school systems benefit from some of these things? We know, for instance, that Kemri Wellcome Trust have a program where they initiate the programs and the processes of research in children as early as primary school and secondary school. So people understand how to grow and mature in research. Now, when people come to hospital, whether it's a pediatric hospital, whether it is for specialized care, the health care providers in these places, is it possible or is there an existence of a training for these health care providers so that when patients come, anytime you go to a hospital or a clinic, you wait. You very rarely do you come in and all that happens is you go and see the doctor. You will wait. That process of waiting, can it be utilized for what is normally called continuous medical education, that people get to be aware when you go there, there's something specific that has taken you there, so that the healthcare providers also know how to inculcate this knowledge during that space of time that is there. And sometimes you're there for a fairly long time. So you're a captive audience.
I think you make many valid points. In fact, what you say is we should begin early in education. And does AKU does that? Yes, I think we should do something better. In October, during Breast Cancer Month, we should not just be promoting mammography, early detection, but we should have healthcare providers go to schools.
Yes.
Primary, secondary schools. By the way, did you know there's breast cancer?
Yes.
Do you know this can happen to your mother or your loved one, or to you for that matter?
Yes.
And here, this is how you can protect yourself. Fantastic idea. The issue that we have also is educating individuals while they are in the clinic.
Yes.
While you're waiting for me, we complain about this at the CEO's office all the time. I keep on seeing the TV with all the news. I mean, you hear about Gaza, you hear about this, about that. But what about what I'm here for? I.e. the physician, what can we do? And when we asked, the cost of changing that, it was much cheaper to have the TV on as opposed to giving an infomercial. So I think all of these needs to be changed. I think these are great ideas, and I'll go back telling my CEO exactly what you said. Said during Breast Cancer Month, above and beyond us giving a free mammogram or a subsidized mammogram, we should have healthcare providers go to schools, talk to young girls and boys about this ailment, because they can then inculcate that into their knowledge base.
Yes.
And when it comes to research, I think we are agnostic. We have KEMRI here. We have a number of fantastic research institutions, better than most places in Africa. But we should do more specifically in cancer, because cancer research is not something we do automatically. We do infectious disease research, HIV, TB, malaria, but cancer is causing more deaths today than all of those combined infectious diseases. And part of what we do at AKU is exactly that, to say that the genome of a breast cancer patient in Kenya is different. So test those drugs that we have in the West on our patients, do their work, and more importantly, maybe develop drugs here specifically for our patients. And before I finish, I should talk about stigma. We're doing research today on stigma. Young men, young women, and older women who had breast cancer get stigmatized by the outside world. Their husbands leave them because they say they're not as good as you were before. Family shun them to say, by the way, you were maybe bewitched, and whatever you have may be infected upon me. 1 out of 3 women with breast cancer suffer anxiety. 1 out of 4 suffer depression because of the stigmatization of the society upon them for something they were not blamed for. We need to improve that as well, and that comes from education. So when we go to schools, we should say, just because somebody has a Band-Aid on his face, don't bully him, ask him what happened. Same thing with women with breast cancer. We should really be doing that, and we don't do that often enough. Partly because of ignorance, partly because of fear, what should I tell this person? And we shun them. And one quote I have from a young woman who had breast cancer, she said, in the past, I'd call my friends, I'd say, shall we go out? So they would expect my call. Now that I have breast cancer, when I call, they think I'm sick, I need help, they shun me. That to me is as bad as the disease itself.
And that is, deep-rooted, actually. You'll hear very many people will shy away from going for a test of any kind because they don't want to find out what's there.
Correct.
Because of what it ushers me into, right? I don't know, you're telling me this is a chronic disease, a terminal disease. How am I going to start dealing with these things? What are you telling me to do now?
Yes.
I don't even have the money, the wherewithal, the mental strength to handle it. And you're thrusting me straight into it. And I took myself there to find out that information. I'd rather not.
Yes.
How do we change that?
I think in the West, I see this phenomenon of openness. Betty Ford had breast cancer, she says I had breast cancer. Schwarzenegger had prostate cancer, I had prostate cancer. We have a number of influencers who influence society to buy this good or the other good, or buy this dress or this makeup. Why don't influencers who have malignancies come out and say, I had it, I got treated, I'm cured, look at me. Our leadership, in many ways, will go out of the country when they have these ailments. In secret, they come back, nobody knew. I think we should have influencers who have these kinds of ailments, including breast cancer, come and talk to say, I'm human as you are. It can happen to me. It could happen to you. Look, I am here. I'm cured. I'm healed because I paid attention to early detection. I wish we would do more of that.
Is our public health system well equipped to actually deal with these non-communicable diseases that are on the rise?
Not yet. I think if we, with everybody, thanks to SPICE, tomorrow we'd have a mammogram, AKU and everybody else will be overwhelmed. But at least then we would respond appropriately and put the resources where they're required. I think we are getting there gradually. We have more mammograms. All the cancer centers in the country that have been opened up don't all have mammography units. But more importantly, it's not just the technology. The machine does not do it. The technician has to be well trained. And once you find the lesion, don't call it BIRADS 1 when you know it's a BIRADS 5 aggressive tumor. That requires more than just technology. We buy machines, we put them in the shops, they call them cancer centers. We have to have more than that. And that requires awareness, education, and the right people. We don't have enough radiologists. We don't have even enough oncologists. I think we are getting much better than most other countries in Africa, but I think it'll take some more time to be where we need to be. Awareness on part of the population, but also society as a whole should invest in, one, funding cancer care, as well as then equipping cancer centers with the right people who have the right knowledge.
You know, there's always a discussion, and predominantly that's what it is, a discussion and a talk about preventative and promotive care. And the cost effectiveness of it is also discussed. With regards to cancer, early detection, prevention, what do we tell people? What do people need to know and understand so that they can actually take the steps to ensure that they limit the chances and opportunities of actually acquiring or actually being cancerous?
If you look at the data, if you find a lesion 2 centimeters by mammography, because it's difficult to find by hand, because in the breast 2 centimeters could be very small compared to your whole breast. You pick up a lesion 2 centimeters which is not spread to the lymph nodes.
What is a lesion?
A lesion is like a lump. Yeah, a lesion is a lump. We use the term lesion when you have a lump that you suspect would be malignant, so we call it a lesion. But it is basically a lump. A 2 centimeter lump in the breast, you cannot feel it because your breast has so many other lumps, breast tissue, etc. A 2 centimeter lump, lesion, with no spread to the lymph nodes in the axilla, which is where they go first, the cure rate there is 90+%. You're alive and well forever after. The cost of care would be mammography, probably surgery. If you want to keep your breast, we take out the lump. For the rest of the breast, we have to give you radiation. And then you may need some chemotherapy or hormone therapy. I can imagine, and just off the top of my head, the cost of care would be about totally, let's say, between $6,000 and $8,000 converted to shillings. But you're cured. You come to me with stage 4 metastatic breast cancer, you spread to your bones in your liver, your life expectancy is about 2 years. The cost of care of hospitalizations is at least 10-fold higher than what it would have been had you picked it up at stage 1. And the cost between stage 4 and stage 1 is the mammogram, which is today, in October, subsidized and cheap. You can imagine, cost economically, that would be better. How do we convey that in a very layman fashion to the common person to say, it behooves you to save some money and get your mammogram? 1 in 10 women in their lifetime will develop breast cancer. 1 in 10. It's not very uncommon.
Yeah, that's high.
That's a very high one.
That is high. That is high. But you know, if you were to look at the prioritizing of what people in our continent have with regards to healthcare, what competes for the resources that they have? Am I going to eat? Are my children going to go to school? Or am I going to go for a checkup? You balance this and ask yourself, what do you think will win the day? It will not be going for a checkup.
That's for sure. All low middle income societies where you are hand to mouth, which is why the government has to assist, has to improve our culture of care by making food accessible, education accessible, and then these kinds of preventive health care aids be nearly free. And I think we're not there yet, but as we develop, as we become more mature, we will get there. But the trouble is, as we develop, become more mature, we assume, we take on Western habits, which to me are even more a cause to getting us to be more obese, more hypertension, more diabetes, more cancer. So we're developing in a good way in some times, but then also in a bad way because societal habits are taken up much easier through the TV than these kinds of promotional about early detection and prevention.
Prof, you talked about just getting to do localized research so we get to understand our cancers, our diseases from our own context. And you and others at Aga University Hospital and elsewhere are leading this. We had a conversation earlier this week with Professor Sam Kinyanjui from the Kemri Wellcome Trust program, and he mentioned the ALMA program that you're running at Aga Khan University. Tell us about that.
I don't have specifics about what did he say about the ALMA program.
So, all of you have come together and did something about neuroscience and getting to understand just how it's basically just extending research.
Correct. So, today, above and beyond cancer, any other disease, non-communicable diseases, mental health is a big issue in this country, everywhere else. So we at AKU have a Brain and Mind Institute looking at the juxtaposition of neuroscience with mental health and physical health. So we met together. We have a study going on, for example, looking at usual stresses of life and how that leads to brain aging. Brain aging leads to dementia. Dementia leads to, as you know, poor quality of life. So we have a study going on evaluating 200 healthy individuals to see what regular stresses of life, taxes, mandamanos, riots here and there, what do they do to my life? Those are stresses. We do an MRI, we give them a Fitbit, we do neuropsychologic testing, and we assess what's going on over 1 year. And then we say, let's induce a stressor into this framework. So we have 25 women with breast cancer, 25 men with prostate cancer who've been early diagnosed, and we put them on the study. We do the same thing with them to say, now you have the same issues like everybody else, but now you've been diagnosed with cancer, you got chemotherapy, hormones, surgery. What does it do to your brain and your MRI and your Fitbit? And we assess you on a weekly basis. When your Fitbit shows tachycardia, we call you up and say, what's happening? Do you quarrel with your wife? Oh, no, I was having chest pain. Well, let's come and have you tested. That study is the first study in Africa looking at brain aging in the context of stresses of life, but then adding the stress of cancer. That to me is a unique. I just came back from a meeting that was in Europe where that was highlighted as one of the first studies looking at mental health and brain aging in the African context. And I think that is a kind of thing that my colleague from Cameroon must have talked about. And there are many other things. We talked about stigma, mental health, neuroscience. I think our dean, Lynn Lucoy, was recently at the cabinet meeting talking about how can we make suicide not a punishable entity, but a mental health issue where we can help individuals. So I think we at AKU, through research, are trying to bring in at least an academic angle to what societal ills are so that we can explain it, study it, improve it, and hopefully improve the quality of life of our people in this country.
I like what you just said about your dean going to talk to authorities and our politicians about this. Because one of the disconnects that has existed for the longest time is how those who are in decision-making positions are ignorant about research processes, the importance of it, and how it contributes to the very things that they themselves are trying to promote. They are not aware. They do not know. They do not understand. My question, yes, the dean went there once. Do you have a program to ensure that people who make decisions on all these matters are constantly informed and they know so that they keep up with it?
Well, it's a big question, but at least we are getting that ivory tower to go to the policymakers. And as policymakers now elect people who are academically informed, then you have this ability to say both the policymakers understand and the academic tower can bring new knowledge so the two can talk together. I think we are getting closer to accepting the fact that suicide should not be a punishable entity, but at least a mental health or at least a societal concern.
You know, Prof, when you talked about how it is that churches and mosques and religious institutions should help propagate these messages, people who are also in the public domain, and for a lot of the time, they are characterized by the nonsensical things they say. That is our politicians, okay? When they are informed about these things, they also get to grab the attention of the populace. And when they know, because knowledge that they can pass on will give them an element of popularity. So it's a win-win.
I agree.
It's a win-win because they'll talk about things which are important, but it's a win-win because they will give the impression to the electorate that they care and they're concerned. So the idea of talking to Parliament and talking to the various, what are they called, committees that they have, whether it's the Senate or whether it's the National Assembly, it's very, very important.
I agree. When I became a physician, people tell me, "Can you go and talk to the policymakers?"
Yeah.
I said, "No, it's a waste of my time. I'd rather be in the lab." I realize today that it's just as important to talk to policymakers, influencers, just as important as being in the lab, because if you cannot translate the discoveries of the lab to the common person, and the intermediate interlocutor is the policymaker, then I've failed in my mission for sure.
Prof, we thank you very much for coming. Give a final message to Kenyans as we have, the final days of Breast Cancer Awareness Month.
I think my message would be to Maini, the message of hope. Today, a woman with breast cancer has a great potential to be cured because we have effective therapy here in Kenya. Not just at AKU, but all our medical institutions. That's one. So if you already have it, remember, know that we can cure you. Number two, if you don't have it, the best way to do and protect yourself is early detection and prevention. High fiber, low fat exercise, health prevention, but more importantly, mammography and self-examination can ensure that you will pick up this entity early in life if it is going to be destined for you, and that ensures better cure. That is our responsibility, and that is my message.
Oh, thank you very much. Professor Mansoor Saleh, consultant oncologist at the Aga Khan University Hospital. He's been our guest on this Health Friday conversation, awareness, detection and prevention of breast cancer. 8 a.m. Time for the news.
Spice up your life.